Hello, hi guys. How are you? I hope you're all good. I'm actually just going to make sure I've got my comments up and ready. Now then, I'm really excited. We have got Dr. Carys Sonnenberg coming on today, and I'm just waiting for her to actually come into the studio. I have invited her. Let me just see if she's coming on. And just while she is, what I wanted to just talk to you about is we have got loads of questions. We had such a good response to last month's Meno chat. And I'm being really excited about doing this one again today because we've got so many really good questions from you. So I'm really hoping that she's going to be coming on soon. This is what I always see on half of the lives when they share the screen. Half the time it's just the battle to get everybody to come on. So let me just double check that she is coming. Here we go. And sorry, bear with me just a moment. Don't you just love technical things? So when Dr. Carys does arrive, I have got a whole heap of questions that I have printed out and got ready to ask her. And what I want to do is, if you do have any questions that we don't answer during the chat and we can fit them in, we will obviously try our very best to do that. Now then, I'm just going to double check that she is on her way because I can't see her on here. And here she comes. Here she comes. Bear with me, guys. Bear with me. Okay. There she is. I'm just going to add her in.
Hello. How are you?
We love these technical things. How are you, Dr. Carys?
Really good. How are you?
I'm good, thank you. Now then, I can see we've got Sarah on at the moment. Sarah, can you just give me a thumbs up that you can hear Carys and myself? Because last time we had a technical issue with sound. So could you just say hello, Carys, Dr. Carys, and just let
yes.
us know?
Hello. Can you hear me? Yeah.
Great. Can you just give me a thumbs up, somebody that you can actually hear? Because I want to make sure that it's not just me hearing you and that everybody can. Oh, nobody's commenting. So I am just going to carry on then. It's lovely to see you. And thank you so much for joining me again today.
It's my pleasure. Thank you for having me.
Loads and loads of questions for you.
Fantastic.
So our last time, we did cover loads, didn't we? We went through quite a lot of stuff. But again, we have got some slightly more intricate questions, as well as some symptom things that I think will be really interesting to lots and lots of different ladies. So the first thing I just want to say is that since our last time of talking, I am now on HRT. I can't believe I've actually gone ahead and done it. I am now 4 days in, and I have to say, it's pretty amazing the difference in just a couple of days. And I want to say a big thank you, because I think actually it was just our conversation that gave me the confidence to go ahead and just do it, because I've been managing my perimenopause for 5 years, naturally trying to just make sure I've worked out all the health and well-being things I need to do. But the hot flushes and the lack of sleep just in the last 8 weeks have just been slightly overwhelming. And that's been your conversation with me. I just want to say a big thank you. So I'm hoping that has helped a lot of other women as well. So
yes, I'm glad you're feeling so. Tell me how you're feeling now. Has it worked quickly for you?
It has actually. Well, I had my first good night's sleep in 4.5 years on my second night. And last night wasn't great because I think I was interviewing you in my mind last night. So, that natural, you can't stop your brain from working. But my hot flushes have eased. I have gone from having them day and night. I've had literally 1 or 2 during the day and then 1 or 2 during the night. Whereas before I had a look on my Fitbit and it was waking me up about 8 times a night.
Really?
Yeah. So I'm gobsmashed. But so I feel now that I'm matching up with anybody else who's got a patch. I've now got the lovely black line around the patch on my bottom with everybody else who's on HRT.
It's incredible, isn't it? I find it comes off after about 3 or 4 days. The first day on removing the patch, it's just very difficult to get off the black mark. But if you leave it just a few days, then you can just have a go at all of them. And then it seems to be fun.
Patchwork. Yeah.
I've tried the gel and the patches, and my husband made me laugh. He's going, "What's happened to your skin?" And I said, "Oh no, just the patch. It's fine." I haven't suddenly developed black spots.
Dirty.
Yeah, exactly.
But So, it's worth it, isn't it? It's worth it when you feel just that little bit of a boost for anything that you've been feeling better. Now, one of the things we've got quite a few things to get through. So if you're all right, we will get started, if that's okay. So I have to tell the ladies on here, they are going to ask some questions as we go, but I will come through to those in a little while. So, the way I've ordered these questions, the first set of questions we're going to ask you are really relating to HRT, and then we're going to be relating to specific symptoms. But I've just warned everybody, and I'll say it again, that Dr. Carys can only give you guidance, everyone. And so she will always ask you to go to your doctor just to double check, because obviously she's not physically with you, and it's not, it's not something that she can almost like diagnose, but she can definitely listen to. We've gone through some of these questions, and you sort of know what's coming, just so that you can give an overview and sort of like as much of information as possible. So give some guidance really rather than anything else. Is that correct? Just so I know I've got it.
That's correct. Yeah, it's because I'm not able to have all your medical information, and when we're covered for insurance to act as a doctor for guidance, I'm allowed to give advice to my own patients, but not to patients who are not at my practice.
Yeah. And I think that's completely valid reason. But you were so helpful last time. I just know it's going to really help loads of ladies today.
Yes. So, I mean, the general guidance tends to be quite helpful, but any individual issues, definitely must speak to your GP, please.
Yes, absolutely. So one of the first questions I had on here, because this is one of the questions that came through, is if you do start taking HRT, how quickly can you feel the benefits? Can it be from the first day, or does it take a few days or weeks?
Okay, well, I think you've answered that question in part, haven't you, with your experience? And actually that the vasomotor symptoms, which are your hot flushes and night sweats, tend to settle quite quickly within a few days. Sometimes it is a little bit longer than that. But the cognitive functions, so your brain fog, your speed of thought, your concentration, your mood, may take some weeks to months to get better. It's very difficult to answer that anymore, to be more specific than that, because women's hormones in perimenopause, and I may have said this last time, change. So when you start your perimenopause symptoms, they don't just go down in a lovely line. It's very fluctuating. So your own hormones are doing this, and we're trying to add something in to catch up. So you can sometimes think, oh, I feel really great. And then a few weeks later, you might think, oh, I feel awful now. I don't think this HRT is working. And actually what's probably happening is your own hormones are fluctuating, and you may need to adjust the dose. And sometimes you need to wait for hormones to settle in your body. It's not, you don't just take something and it's a quick fix, for example. It just takes time to get settled. And in perimenopause, because things can change so much, it does take time. And that can be a number of years that perimenopause goes on for. Once you've gone through the menopause, things are more stable, so it won't always be this way, but it can seem almost a bit difficult to manage, and you feel good and then you don't feel good, and then you feel good and then you don't feel good. So yes, but the actual vasomotor symptoms, if you're on the correct dose, should settle quite quickly. Just one thing just to point in there is that a lot of my ladies are tentative in starting. So they might use one pump of the gel or something, and that might work beautifully for them if they absorb it really well through their skin. But if they don't absorb it very well through their skin, they really won't be treating themselves well enough. So the dose, there's a lot of anxiety about the dose that people seem to be on. They seem, I'm on like 4 pumps, oh my word, my friend's only on 1, and why am I on 4? And it's because we don't absorb things through the skin in the same way. So I might need to give one lady 2 pumps, and I might need to give another lady 8 pumps in order to achieve the same estrogen level and the same relief of symptoms. So don't get too worried about the dose. So if your GP is giving you two 200 microgram patches, and your friend's only on a 25 microgram patch, don't panic. It's just because you're your own body, and your symptoms and your absorption has got to be the important thing.
That's really good to say that, because actually, even when I was with my GP, she said, well, I'll start you on 25 micrograms. And then she said, oh, actually, no, it's advising me not to. So she was actually, she was just reading the chart. But absolutely, I know that my sister, for example, she was on patches, and then she found out that she wasn't absorbing transdermally well enough, and that had to go back onto some pumps of gel to try and top it up because her body wasn't absorbing. So that's a really good point to make, actually, that yes, it might need to be adjusted as you go as well, I'm assuming.
Yes.
Okay.
So, and if you find that you're okay and then suddenly your symptoms come back, that's often a time when I would do a blood test to check the estradiol level. If you're on transdermal estrogen, that works. If you're taking oral estrogen, that doesn't work. And then often I might see, yes, those levels. It's a bit difficult when it comes to blood tests, because I might take a blood test and the result might be, say, 350 picomoles per litre, and I might say to that lady, well, great, your estrogen is well within the limits that we would expect. But she might say to me, well, actually, I still feel awful. I've got still sweats and I still feel this. So we've got room to tweak things. Not everything is about the blood test. We have to look at you clinically as a person and see what symptoms you're having, and what dose you require to relieve those symptoms. Everybody's individual.
Yeah, I mean, I think that's quite interesting, because I think that one of the questions we've got coming up will be about blood tests. And I think, everybody expects whatever's read through that blood test is going to be the thing that will fix you. But it's not the case, really, is it? Like you say, what you're feeling and what the test results are, they don't necessarily always balance up. So that's good to know that you're listening.
And the blood test is a snippet of time. Okay. So it doesn't mean that the next day or the next week your estrogen level is going to be at that level, because you could have just caught it at a really high peak and then you could be on your way down. So blood tests can be useful, but they're not always everything.
Right.
We need to listen and look at those symptom charts. So the Balance app has an amazing symptom chart, or you can use any one that you like, as long as you know you're looking for all the symptoms and it's not just about the hot flushes. Yes. There are the other symptoms as well.
The hundreds of other symptoms that seem to come up. That's brilliant. Thank you. So another one that's been an interesting one is I've been asked by a few ladies, especially in the groups that I work with, does HRT make you put on weight? And I know that a lot of women worry about this. I mean, I know when you're going through perimenopause, weight gain is quite an obvious thing sometimes for a lot of women, especially around this band around your middle. But I don't know, on contraception, sometimes you can actually put weight on, or it seems to be, when you actually are on more of an estrogen-based contraception. So, yeah, could you just explain sort of like, does HRT cause any weight gain or fluctuations and that sort of thing?
So there's no evidence that HRT causes weight gain, but menopause does cause weight gain. And the reasons we start with insulin resistance. So when we become menopausal, our insulin resistance increases. Yeah. So when we eat some sugar, and it doesn't have to be sugar, it could be carbohydrate, but anything that's broken down into glucose. So that glucose rushes to our cells in order to try and get in to make energy for the body. And in many of the cells, insulin is required to open the door for the glucose to enter the cell. So the pancreas would release insulin when you get a boost of sugar. And so the insulin and the glucose arrive together. And then suddenly there may be resistance. So the insulin can't open the door. It's trying to push the door open, let the glucose in, but no, it's not happening. And the glucose is in the queue. It's getting a bit bored, thinking, where am I going to go? I can't get in here. Let's go to the liver. Right, I'm going to go to the liver. I'm going to make glycogen in the liver. And the liver opens the door. Yep, in you come. Right, oh, now we're full. So there's this glucose left in the body. And where does it go? It goes to the fat cells. And the fat is very happy to let it in. So it gets in there, settles in, and it's going to take a lot of work to get that glucose to come out again. So we do, that's what insulin resistance is in a very basic way. So that causes us to gain weight more easily. Also, when we're menopausal, we have our fat cells produce estrogen, which is another type of estrogen. So our body's a little bit keen to hang on to fat cells because it wants to keep its dose of estrogen as high as it can do. And the other reason is, we get older, we are less mobile, our joints hurt, we don't move as much. So it's so important that we look at what we're putting into our body. So really cutting out processed food is just so important. really cutting back as far as you can on sugar in the form of carbohydrates. So any high glycemic index food that's going to make your sugar whiz up. So you should be having a high protein, low glycemic index diet to try and avoid that weight gain, because even fruit, non-seasonal fruit, lots of people eat a lot of fruit. They think it's really healthy. And actually, it's so full of sugar. It's like a big Haribo, if you're not eating if you're eating a lot of it. One of my patients was thinking she was being really healthy eating watermelon and was eating the entire watermelon. So, that's packed full of sugar. So, but she genuinely thought that was really good, full of vitamins. And yes, there are, vitamins and minerals in fruit, but really it is very sugary. So you need to be a bit careful with how much
portion control. Control is, I think, is definitely
really
something
important. Yes. So those things. So we maybe have beliefs about our diet that are different, our movement's different, our insulin resistance is different. So HRT, in answer to your question, it does not cause weight gain, but menopause and the changes in your body can cause that. So in theory, taking HRT when you increase the estrogen should reduce your insulin resistance, which should in turn, and also should make your joints feel better. So it should in turn, therefore, it doesn't cause weight loss, but it may contribute to you being able to lose weight because you feel more active, you feel better in yourself mentally, less anxious, less low. So all those things will help.
Oh no, that's brilliant, and I think you explained that so beautifully about about the insulin, because I think that's not something that a lot of us talk about all the time, and sort of like you're always looking back on how you were in your 20s and 30s rather than what's the actual cause of these things. So no, that was so really nicely explained. That's great. And actually, I'll be honest with you, I feel less bloated in the last 2 or 3 days now. I don't know, I didn't think I was bloated before, but I definitely feel that I feel calmer, and I do feel that, my body feels like it's processing things properly. I might be just looking for it because I am so new on it, but I'm just, a bit excited maybe, but I definitely feel something's happening. So I'll be looking forward to maybe the next month, see how that progresses.
See how it's going. Well, estrogen increases your serotonin in your brain. So your serotonin is one of your neurotransmitters. It's amazing. So they're not just hormones, they modulate the neurotransmitter releases in the brain. And obviously serotonin is 95% receptors in your gut and your brain. And because of the communication between the gut and the brain, it does make you feel good. It's one of your feel-good hormones. So estrogen will increase that. So that will help your gut, because symptoms of IBS can get worse when you have menopause. So you feel bloated, the gut transit slows down, there's more wind, you may be a bit constipated and a bit of diarrhea. So you need to just be careful you're talking to a doctor about any change of bowel habit. And we can't just put everything down to the menopause, but that can happen through the menopause. So if you take estrogen, it can help to increase the serotonin, which will make you feel better, and also to help settle your tummy symptoms.
Oh gosh, I'm loving it even more now. That's great. Okay, so I've got a question actually about combined HRT. So if you're on combined HRT and have a bleed each month to discard built-up lining, how do you know your periods have stopped for a year so you can go on to just estrogen-only HRT? And I think that's a really good question.
Yes. Okay, so there's lots of parts.
I was actually wondering that. How do you know when your period?
So let's start from the beginning. So combined HRT. So if you have a womb, you need to take combined HRT. So that means you take the estrogen part to relieve all your symptoms of menopause, and you take the progestogen or progesterone part to protect the womb from endometrial thickening, because estrogen will make the womb lining thicken, and that then increases our risk of endometrial cancer. So progesterone would be in the form of something like utrogestan, which is a body identical progesterone. And it is the same makeup derived from the yam plant, the same makeup as our own body progesterone. Any other progestogen is synthetic. So the one that surrounds the Mirena coil is levonorgestrel. You could take hydroxyprogesterone acetate, you could take norethistérone. So there are other progestogens, they're all synthetic. But the one that we tend to try and use now is the progesterone, because we know it's newer, we know it's got low risk of breast cancer in the first 5 years, certainly no risk of breast cancer has been found, and we know that we're looking at things after that. Again, a Mirena coil is an excellent method of giving your womb protection with progesterone as well. So combined HRT is those two. So you've got sequential combined HRT and continuous combined HRT. And when a lady starts on their perimenopause journey, they'll go and see their GP. Perimenopause is when you are having your periods, and the menopause is the day that you have not had a period for a year. Say you're not taking HRT.
Yes.
So that then you are now menopausal. So in the perimenopause, things fluctuate, as we said, so much that if we give you continuous combined HRT in the form of daily Utrogestan and estrogen, you will just bleed all over the place because your body isn't ready, and you'll find it really frustrating. So we give you sequential combined HRT, which means that you have your Utrogestan for 2 weeks of 12 to 14 days of the month in order to protect the womb from endometrial cancer. And then you should have a bleed each month to shed that lining, because that's better while you're settling into the perimenopause. Now, there's no magic rule as to when we switch you over to a no bleed preparation of continuous combined, but it tends to be when we think you're ready, when you're fed up of having periods, when it's more than a year anyway, certainly. And then you are still on combined HRT, but it's continuous combined, but you never go on to estrogen only. So that's the progesterone or the progestogen is always going to be needed if you have a womb and you are taking estrogen as part of your HRT. So the safest way to take HRT would be transdermal. So it's either going to be in a gel that goes on your body or in a patch, and a progesterone or progestogen to protect your womb. So as long as you stay on HRT, those two things are necessary.
Right.
If you do not have a womb, so you have had a hysterectomy, and it's slightly different for endometriosis, but if you've had a hysterectomy, then you only need to take estrogen because you don't have that womb thickening because you don't have a womb. So you don't need to protect the womb with progesterone. Or progestogen. If you have endometriosis, because we know that endometriosis is where the lining of the womb is found in other parts of the body. So you get it anywhere. You get it on your legs, in your nose, in your brain, on your chest, anywhere. And every month that bleeds a bit, and it can be very painful. It's a really, really painful condition. Lots of nerve growth, lots of inflammation. So if you take your womb out because of that, because it can cause, you can have deposits all around the bladder and around the bowel, you're still going to have lining of the womb in other parts of the body. So you do need to take progesterone or progestogen then. So it's a continuous HRT, continuous combined HRT. So just because you had a hysterectomy, if you have endometriosis, doesn't mean you can just take estrogen only. But if you don't have endometriosis, then you can avoid the progesterone part. So you'll never stop the progesterone if you have a womb.
So there isn't a time. So when you do get to the point where you said that, you want to stop having, you will have stopped having periods. I'm just a bit confused. Sorry.
No, that's fine.
So if you, so what happens at that stage? So say, for example, you are in postmenopause, and you just, you still want to stay on HRT, but you just get given a little bit of a lesser dose of the progesterone just to maintain the fact that your womb is still there.
It's a really good question. Sorry, I probably haven't explained it very well. Well, so when you're on your sequential combined HRT means that you use the progesterone in a cyclical way. So on, off, on, off.
Yes.
When you are continuous combined, you just take the progesterone continually.
Right. Sorry, that's what I missed.
Sorry.
That didn't
yeah, so you would have a Mirena coil, which is there all the time.
I see what
that doesn't really, that sort of issue doesn't really bother us when you've got a Mirena coil, because it's there all the time. You don't have to worry about being on, off, on, off. It's if you are taking oral progesterone that you need to, sequential combined will mean you take it for 2 weeks on, 2 weeks off, 2 weeks on, 2 weeks off, and then when your body's all settled, things are a bit better, you will then take it continually. So you can take it orally. Some women take it vaginally. It's not licensed that way, but it can be used that way if you're very sensitive to the side effects of progesterone and progestogen. And about 20% of women are very, very sensitive. They feel terrible when they take it.
Yes, I'm going to have to say I'm not looking forward to it. I haven't got to that bit yet. I've got to get to day 14, I think, on mine. But I'll be contacting you if I have any issues.
You can ask
You're like, no.
That's fine. I mean, if you haven't had issues so far in your life with a contraceptive pill, and really you haven't really suffered from PMS or PMDD, then it is likely you'll be all right. Particularly if you're on the progesterone, because progesterone rises in the luteal phase of our cycle, because it's made from the corpus luteum after we ovulate. So women usually find that they've suffered from PMS, premenstrual syndrome, or PMDD, which is very severe premenstrual syndrome. And when I give them a combined contraceptive pill, they come back multiple times wanting to change it. This one doesn't suit me. I don't feel right on this. And there are lots of women who just cannot take progesterone or progestogen. It just doesn't suit them. And it goes up to their GABA receptors in their brain. And the GABA receptors are what we call bimodal. So it means that some women, you could load them up with progesterone, it gets metabolized to allopregnanolone, which is its metabolite, goes up to the brain, and they are fine. Other women, you give them a little bit of it and they feel terrible. It just is the way it affects our brain. We're all very individual that way.
Right. So obviously if that does affect anybody, the progesterone side, they can actually get that adjusted, and they could actually try.
Yes. So you can try. So eutregestane's possibly the best tolerated, because that is the same as our body makes.
Yes.
You can take the progesterone, the eutregestane, under the advice of your GP. Don't just change it, please. But you can take it vaginally, and the reason that is that if you absorb progesterone vaginally, it makes less allopregnanolone, which is the metabolite, and that's the thing that goes up to the brain. So.
Right. Okay.
That's why I add all this bit in, and you might think that's not necessary, but it is good to understand why. I really am a big fan that people understand what they're doing and why they're taking things, because if you don't, then it's very difficult to make head or tail if it's working or not.
Absolutely. No, I love to find out the whys, because it just means that you understand why you're feeling the way you do. Now, I am going to just slightly come off, because interestingly, we've had a question from the group, which I think I mentioned very briefly into a message to you, to say that there's a lady who's postmenopausal for many years and has had symptoms which have been progressively getting worse. And then she went on to the combined HRT last November. She saw an improvement, but then the bleeding started. So she was obviously postmenopausal for a long, long time. Then the bleeding started, and what she found was she's obviously seen the gynecologist, and she actually had some polyps removed, which is good, but the bleeding still continues. And then she switched to patches, same thing happened. And now she's better. She was told via text, which absolutely infuriates me, but told via text just to stop HRT completely and go cold turkey. And so now she's thinking, okay, what does that mean? Will my symptoms return? Will that stop the bleeding? And also, is there anything else that she can take? Because when she was being on HRT, all her symptoms were actually feeling so much better that she's really worried that if she's got to stop HRT, will everything just come rushing back? So I know it's quite a broad one there, but the bleeding thing, when you're postmenopausal, is that quite normal? When you're put on HRT, that you actually get a bleed?
That's a complicated one, isn't it?
Sorry, I know you're not going to be. You're not going to. This is just going to.
No. I'm going to just talk generally. That lady, I would suggest you go and speak to your gynecologist again. So when you give estrogen, you can cause thickening of the womb, and you can get some bleeding as things settle down. And usually, when we give when we start HRT, we might find some bleeding happens in the first 3 to 4 months. If it goes on beyond that, we really need to be doing an ultrasound scan and a blood test to check for a cancer marker. That's what our gynecologists say that we should do. And if necessary, if the endometrium lining is thick, then we will refer for a little hysteroscopy and biopsy, which is a tiny camera that goes in, they take a few of the cells. So that lady's obviously had that done. So causes of abnormal bleeding, fibroids, adenomyosis, polyps, endometrial cancer. Endometrial cancer is actually quite rare, but it is theoretically possible, and that's what we would always worry about in anyone with abnormal bleeding. So if they've removed those polyps, they've removed the cause of the bleed, why she would be suddenly asked to come off her HRT, I can't understand.
No, she's been, and it's been bleeding continuously. It's like it's not like she has any gaps between it. It sounds like it's something
it's
that's
all the time. So you would need to then look at what progesterone or progestogen she was having. Has that been changed? Because often we may need to change from utrogestan to an older fashioned progestogen like medroxyacetate progesterone or norethistro. That's what the BMS suggests that we do. So that's a possibility. Inserting a Mirena coil is a possibility. Having hysterectomy is a possibility.
Right. So really what she needs to do is go to see her gynecologist.
Discuss the options.
And just discuss the options. I think, you know, the difficulty, I mean, I can even say this from my experience, it's just getting the appointments. You know how frustrated I was before mine. So, yeah. I mean, it's just trying to get in. I mean, the fact that she's been told this via text, I think is just awful. You know, just really poor.
I mean, there's various ways of communicating, and to be honest, we do use a lot of text now because but yes, there are some things that are better done on a conversation, so much better done face to face, and I'm very much enjoying seeing my patients face to face. Yes. So
would you say that she should stop taking the HRT or wait until she gets an appointment?
She's got to do whatever her doctors have advised her to do. I couldn't say that she shouldn't do that, but what I would do is say she could make a telephone appointment to discuss that with her GP, and I do that all the time with my ladies, and if necessary the GP can then make a referral back to the gynecologist. It's always a possibility to phone a consultant at the hospital secretary if you've been under their care and if they've discharged you, then they'll want a GP referral back again, but if they haven't discharged you and you're still under follow-up, you could happily leave a message with the secretary and say, look, I'm a bit confused, I really think I'd like to talk about what my options are. There are always options, there's always choice, and you just need to look at often things come with risk, I don't fully understand all the whole thing of that story, but for if you are finding that you've been told to stop your HRT and you don't want to stop it, then you would be really well placed having a conversation to understand exactly why.
Yes, absolutely. Thank you so much. It's just because when we were talking about the combined HRT and when to know to finish, I just thought I'd just add that in because that was a post-menopausal thing. So one of our ladies has actually read that when you take HRT, it can deplete the vitamins in the body. So is this the case? And if so, what are good vitamins to take to support you when you're on HRT?
Okay, yeah, I looked at that question. That's really interesting. I didn't know that. I have not read that. Any course that I've done has not stated that. So, no, I don't know. And if that's the case, I'd love to see the evidence. Yes, I always say that because, you know, there are things that we can't know everything, but I think that I didn't know that. No. So, and regards to what we can take, gosh, it's really difficult, isn't it? I listened to this incredible podcast this morning. So the Newson Health Society podcasts are really brilliant. Yes. And they do recommend a healthy, balanced diet. And if you vary your vegetables and introduce new things, you're having a high protein diet, whole grains, lots of nutritious vegetables, avoiding sugar, avoiding processed food, you're likely to get most of the things that you need. If you have time outside in sunshine, and actually one very interesting thing I learned this morning was that you can absorb vitamin D through your skin from sun if you have sun cream on. Now, until today, I had always, everything that I have read and all the courses I've done has suggested that isn't actually the case, but that's what I heard on the podcast this morning. So that was quite good. So getting outside so you don't burn, so you safely absorb your vitamin D, and you need to be taking what the NHS recommend you take supplements for vitamin D in the winter, because in this country we probably don't get enough sunshine and a lot of us don't spend enough time outside to make enough vitamin D, and that is super important for your bones. So osteoporosis risk goes up when we have menopause. It's really important. Another thing to look at is calcium. So not taking supplements, but getting it from your diet, and probably looking at how you get it from your diet. So there are various websites that you can look at to see exactly how much. And pre-menopausal, you're going to need 700 milligrams of calcium a day. Post-menopausal, 1,200 milligrams. So it's really important that you look after your bones that way. regards to other vitamins, and vitamin K is important. You can get that from your diet. You don't need to take a supplement of that. Magnesium and zinc are important. But again, if you have a wide ranging diet, you should be okay. There was another question on probiotics.
Yes.
Is that necessary? And it was very interesting. They were talking about the gut microbiome, because I know it's really interesting how that can affect our body, how what we eat can affect our body. And it is so important to watch what you're eating at this age, or at any age, really. So that was very interesting. And it was stating that actually there's no real evidence for using probiotics. And the jury is out, but from what the evidence that this lady was looking at, she was a nutritionist, she wouldn't endorse that, because a lot of us think, oh, well, if I've taken antibiotics. It was one interesting thing, actually. They said if you take antibiotics, some of them can wipe out your gut microbiome for 2 years. And actually people think, oh, I'll just top up with a bit of probiotics, but actually that can impede the bacteria regrowing. Wow. There's a lot of evidence, and I am not a nutritionist or a dietitian, so it is not my area, but that's what they were speaking about this morning. So often you will read different things in different places.
Oh gosh, absolutely. Oh no, I'm intrigued by that, actually, because that's quite different, completely opposite to what we're told, isn't it? Everyone should be on probiotics and things like that. Just had a thank you from the lady who we just spoken about, and she's going to speak to her gynecology in 10 days. So we'll look at the options, but better informed now to the question. So thank you. That's great. Brilliant. Okay. Okay. We've just talked about fibroids and uterine polyps, but regarding Everol and other versions, so obviously Everol is Everl. HRT. If you have existing fibroids or a uterine polyp, can the drug increase these? So if you're more susceptible to those, does HRT increase those occurring?
So not necessarily polyps, but fibroids are estrogen loving. So if you take HRT, so when you have your fibroids, as 70% to 80% of us do, once we get to around the age of 50, sometimes they're the size of a grain of rice. Other ones can be absolutely enormous, come up right up to the diaphragm. So it depends what type of fibroid you have, but all of them love estrogen. So when you go through the menopause, they will naturally decline. But if you take HRT, there is a thought that they won't decline. So most women don't have trouble with their fibroids. Some women really do. They get the most terribly heavy periods, a lot of pain. So some women need to have operations to remove their fibroids. But it depends whether the fibroid is in the muscular lining of the wall, whether it's protruding into the womb, like sticking in, or whether it's protruding out. And that then could cause pressure on the bladder, pressure on the bowel. When you have sex, it's uncomfortable, give you pelvic pain, and lots of symptoms if they're really quite enormous. So the answer is yes, it can, but I don't think many people worry terribly about it unless they have serious issues with their fibroids.
Okay, that's good. I mean, it's a tricky one, isn't it? You're almost like you can't you'll have to guess it really for your own body, won't you, for those sorts of things?
Yeah, you would probably know if you had that sort of thing. And what they often do to treat fibroids is one of the options is to take a medication that switches off your estrogen, and that will then try and shrink the fibroid away. Other options are surgical managements. You can use uterine artery embolization. So they try and cut off the blood supply to the fibroid. There are various amazing things they can do if you really suffer with your fibroid, but you would know that was happening to you. Things would be you'd
have known this for a while.
Yeah, I've seen some women who bleed so heavily they become anemic. Hemoglobin goes right down to 4. Or lower, and need hospital admission for intravenous blood transfusion. So really, women, those sort of women, you would be talking to them quite seriously about the risk balance of what they wanted to do. It does come down to choice. If a woman like that has terrible symptoms of the menopause, you've got to really decide what is going to be the best option for you. How can we help you? Not everybody fits into the box of managing things simply. There are some cases that really do require very difficult conversations.
Oh my goodness. honestly, I take my hat off to you. Okay, I've got an interesting one about testosterone, if that's all right.
Yeah.
So this lady has been to Newton Health and actually is on Androfem, and the tube of that is £80.
Yeah.
There must be a cheaper way for women to be able to get hold of testosterone. And I'm hoping that you can say that there's a great brand that we can all go and ask our pharmacist for, and that we can just bypass the doctor on this. But I'm sure you're going to say no.
Well, if you talk to Dr. Zoe Hodson, who is really, really keen about all this, then I think she's attempting to make sure that happens. So currently at the moment, so the guidance has just come out regards to NICE and the BMS, not just come out. There's been another note this morning stating that we can prescribe testosterone for menopausal women who are well estrogenized on the NHS, if only if they have low sex drive. So the benefits that we are seeing and that Louise Newson will see are incredible. You know, I'm a supporter of choice, and I'm a supporter of using these sorts of things, and I prescribe it on the NHS, so I'm totally fine. But the BMS are saying it is not licensed for cognitive function or energy or all these other benefits that we are actually hearing that are coming through the chats on menopause. So things may change in the future. So essentially, so my experience is I shouldn't be prescribing it because it's an SC on it's an amber thing on my formulary. So in order to get around that, because I'm doing the BMS course and because I feel confident prescribe it, and I don't mind prescribing something that's off license if I know it's safe and I'm happy to prescribe it, I will give it. So and I wrote to the gynecologist in charge of the gynae team at our local hospital and said, look, I'm really happy, these are my qualifications, I'm totally happy to do it, or would you like me to refer all my patients who'd like testosterone to you? And she wrote back very quickly and said, no, it's totally fine, yes, you here you go, here's the schedule of sort of what you can do. So which was really kind of her. So now I am able to prescribe it, even though it's an amber SC. Nice. So that's the first thing to do. So some people won't be as keen as others are on menopause. They will be another area with their expertise. So they genuinely won't feel comfortable prescribing it. That will be for two reasons. It's not on their formulary, so they shouldn't be giving it. And secondly, they may not have been trained in that area. And thirdly, it isn't licensed for use in women. So that means the drug companies didn't make it to be used in a woman. It doesn't mean it's not safely widely used in women. It just means the drug companies didn't make it. So when I prescribe something that's off license, it's on me. So if I can't get someone to defend me for that, unless maybe that's not strictly true, because it's widely used and safely used, it should be okay. But a doctor does have to take that risk. So if something's off license, we have to make that decision. So there are lots of GPs who are being put in quite a difficult position because they're being made to feel they should be giving this when actually it's really, maybe those three things are quite important for them. But so if I talk about it, yes, Androfem is great. It's a licensed testosterone that's come from Western Australia, female testosterone, and yes, we can give it privately. It costs about £1 a day. And that's, I know, what Newson Health really like to give, and that's great. On the NHS, you can take a 1% or 2% testosterone gel. They give you a little tube, and you take it every day or every other day, depending on the strength. And then after 2 months, we would check your free androgen index and expect that to be in the range of about 2 to 5%, which is a female level. It's going to take about 8 to 12 weeks for your testosterone to work. Can only be prescribed on the NHS if you have low sex drive. So you have no sex drive, and that's the reason that we would be able to give it to you, not for the other benefits that we can see with testosterone. And that's the guidance that we have. Once you're free and once you're settled on it, we give you a 3 to 6 month trial. And if it really hasn't made much difference, we would at that point be saying, we don't need this. I mean, I've used it, I'm using it. I've had great response for people on it. Still early days-ish, but I've had one lady whose level went up really quite high into the male level. So I had to phone her and say, I
come off it.
Stop this. Yeah, exactly. She was fine, but I think we need to stop this. You're obviously a really good absorber of this sort of thing, and this isn't. I don't think we need this for you. And other people I found have felt really unwell on it. So it's sort of. It's become the thing that we all think we should have, but I'm not sure
I think it's the brain
Everybody
clarity that we've
needs it.
been told it helps with the brain clarity and that. And now I
Yeah.
actually just got a question that's just come up actually, Dr. Carys, saying, does testosterone cause paranoia or any similar side effects?
Not as far as I've ever heard.
No,
but I don't, you can never in medicine say never.
No.
But I have never heard that. No.
Would any of those things come from any of the HRT? Would that come from progesterone or progestogen or from taking HRT in any way? I'm just wondering whether this lady takes HRT as well. If you do, just put a little comment in just so I know. But would any of those? I mean, I know sometimes, if you suffer with PMS symptoms, that can make you feel horrific. And if you get triggered by you saying about progestogen possibly or progesterone, that maybe that might be the feeling rather than it being from testosterone, maybe. I'm guessing.
I think if we're going to, we'd be speculating. And I think I have never read that about testosterone. And I've never read about hallucinations or delusions or anything like that related to progesterone. But women with PMDD can be seriously affected with them in their mental health by that. So, and they certainly can find that they have suicidal thoughts and they become really unwell. As far as delusions and hallucinations go, I don't think so, but if that's the case, I'm sorry. I haven't read it that's the case, but I
haven't had anybody coming to you with that side effect either, it sounds like.
So. There are 11 criteria that you look at when you're diagnosing PMDD, and that you've got to have the top 5 criteria, and I would need to look them up.
Oh, right. So I've just got a little answer to this. Yep. Have patches and a coil. Been taking testosterone, but wasn't too sure of benefits, but found my levels of anxiety increased. So just wondered if there was a link.
Testosterone doesn't seem to suit every single person. So whether your levels of anxiety increase, okay, so maybe your estrogen isn't enough, so that would definitely be a conversation with the GP. Okay. So just because you're on the testosterone, are your blood levels right? Is there another cause for your anxiety? We can't, and I always say this, we can't put everything down to menopause. Is there something else that's going on? You need to have a talk then, please.
Yes. Yeah. Okay. No, that's great advice. Okay. So we have got a little bit more of a symptom style thing here. If I can just go on to this one. I'm having trouble controlling flushes, and I've been on HRT, and she's on HRT despite a high dose. My GP changed me to continuous HRT, as I've been on HRT for 3 years since I was 46. So she must be 49 now. I felt a lot better taking the Utrogestan daily, which she started in December, but having a lot of spotting. This is the bleeding side of things again. I have had a vaginal scan, which was okay. My GP thinks I need to change to progestin to control the bleeding and stop the hormonal fluctuations, as I'm still perimenopausal. Mm-hmm. She also mentioned possibly going on a combined contraceptive pill for a couple of years. She told me to have a think, do some research and go back and see her. I mean, she's putting the emphasis back on the patient really to find out what she wants to do and come back. I mean, I wouldn't even know where to start with this. Please, could you tell me which you think would be best, and if incorporating progestin, which one you think works best? So I know it's only guidance again, but what do you think?
I think your GP's done a great job at trying to balance things around for you, because that sounds like your case was complicated, and not everything is simple. So yes, and things are changing, as we know. So I can't tell you what to do because that's definitely got to be a conversation between you and your GP. But what I do guide people with regards to bleeding is that Utrogestan isn't so great for bleeding control, and other progestogens are. And the British Menopause Society has got some medroxyacetone progesterone acetate and norethistérone can be used instead in order to get better bleeding control. So so that would be if I was dealing with a patient who was having bleeding control, right? Regards to whether you take, any person takes the combined contraceptive pill or the HRT. So you can take the combined contraceptive pill up to the age of 50. It contains estrogen and a different type of progestogen. There are quite a few. So they are synthetic progestogens. And yes, that will act as contraception. Most women, many women need contraception up to the age of 55, but you shouldn't take the pill up to the age of 55. That needs to be stopped at 50. So if you're nearly 50, it would seem a strange decision to go on to that for a few months to me.
So, but years, this doctor said.
Yeah, that isn't something that the Faculty of Sexual and Reproductive Health would recommend. They recommend you stop the pill, the combined contraceptive pill, at 50. Right. If you can take it up to 50, depending on your risk factors. So I'm just having a little think regards to risk benefits. So if you're not going to get the same benefits from your health through taking the combined contraceptive pill as you will through using HRT. So HRT, we know, reduces your insulin resistance, reduces your risk of diabetes, reduces your risk of osteoporosis, reduces your risk of cardiovascular disease if started within 10 years of menopause. There is evidence to show it reduces your risk of dementia, reduces your cholesterol, reduces your osteoarthritis. So there are lots of benefits that we now are seeing with the use of hormone replacement therapy that are not there evidence based on your combined contraceptive pill. So I hope that answers your question in a roundabout way.
Yeah, I mean, I think I don't think there's going to be I think it's going to be having to just try one or two things and see over a period. It's the fact is we can't resolve things like that. It's over a period of time. You have to almost like give it some time to see what works. I'm sure, I think that's probably the best that she's going to get, without her being right in front of you. So I really do hope that helps her just get a little bit of a handle on what she might need to do. So thank you. Okay. We've got one lady in the group has started sleepwalking and shouting. Her dreams are crazy. Her memory is shocking. She forgets what she's done the day before. And she also has a huge bloated belly that looks like she's heavily pregnant. Any advice on sleepwalking and bloated belly? And lots of women actually do deal with this bloating belly feeling. I do understand that my digestion went completely to pot when I've been in perimenopause. So what would you suggest? I mean, is this related to menopause? Is sleepwalking and sleep shouting and talking, are those sorts of things part of menopause? Oh goodness.
Not that I've heard, but I suppose when you have dreams, that's part of your REM sleep, isn't it? So we all, rapid eye movement sleep, we all have a sleep cycle. So we wake up through times in the night, maybe 2 or 3 times in the night. And that's the time when we go into a less deep sleep, and that's the time we would dream. So I'm not quite sure why she's sleepwalking. I don't think, or I've certainly never heard that in menopause. And the bloating, yes, as the gut reduces the transit time, you can see bloating and wind and changes in your bowel habit. But number one thing, bloating, you've got to see your doctor with that, because any ovarian changes, risk of ovarian cancer, for example, in anybody who's, for example, losing weight, who's bloating, needs to be examined, please.
Okay.
Don't just put it down to menopause.
No, I mean, I think really maybe she needs to have a look at just maybe her stress levels might be something that really has exacerbated her sleep patterns and things. And obviously, if she's saying her memory is shocking, it doesn't say whether she's actually on HRT or anything like that, but would you suggest that maybe HRT could support things and just obviously with memory and with sort of like just balancing the hormones?
Those things all could could be to do with, yes, stress, certainly. So making sure that she's having a healthy lifestyle, looking at her diet, looking at her exercise, and weight bearing exercise. But those things don't fit into a pattern. So a really detailed history and examination with your GP, maybe even a blood test and an ultrasound scan to check those ovaries. I'd be much more looking at that side of things first. There are certain things that I hear that I would concentrate on completely until they were sorted out, and then I would take up the other things. And the bloating does bother me. A FODMAP diet is also really good. Have you heard of that?
No, what's that?
Quite difficult to follow, but it's called FODMAP, so capital letters FODMAP, and that tends to be the recommended diet for people who are struggling with IBS. It is quite a tricky one to follow from what I can read, but it does help with the wind symptoms. But bloating is a GP appointment.
Bloating is a GP appointment. Bloating.
And then all those other things can be talked about, but please don't let that go.
No, that's great. Thank you. Okay. So we had this statement in the group yesterday. I have suffered menopause symptoms since I had an operation to lift my pelvic floor with mesh. 2 weeks later, she had a massive stroke and she was fully aware of the situation throughout. Sounds horrific. Nice. However, her periods never returned after the pelvic floor lift. I'm just trying to see if she's got her age on here. There's no age, I'm afraid. She says, I sweat almost constantly every day, cry at the slightest thing, a very erratic sleep pattern. And she used to sleep soundly. So now she's like a bear with a ghastly head, so she's in a bad mood all the time, better. And she has no desire to even think. Sorry, let me just think. I think it's basically she can't control the depression. And in capitals, she's put desperately need some intervention, please help. If you can come back with some first step protocols on really how to manage this. I mean, it doesn't sound like she's been put onto anything that supports her in terms of HRT or anything.
That's really difficult. I'm sorry you're suffering in that way. That does sound really difficult. Yeah. I think you need to go and speak to your doctor about, it's very difficult to speculate about cases like this because I don't know all the information.
Yeah.
So a conversation with your doctor regarding all your symptoms and writing those down before you go to the appointment, because it's so easy. All of us should do that. It's so easy to forget things when we're in there, and then you realise you haven't had the question answered, and it takes a long time to get another appointment. So please write everything down, and you need some help. You need to go and speak to a GP, please. I wouldn't know where to start with answering that question without more information. I'm sorry.
Yes, but I mean, bless her, that sounds just horrible. I mean, obviously with things like, the PMS sounding symptoms where, you're feeling sort of like that, sort of like readiness, anger, or just constantly feeling low. That's, some women have sort of like got that feeling of that sort of dark cloud over them. And you just don't know where to start. When you're in that space, it's so difficult to see the wood for the trees, isn't it? It's almost like you need someone just to say. So the best thing is just go to your doctor if you can. Even do a conversation on the telephone and just, as you quite rightly say, write everything down. Write it down as a list that you can just almost like regurgitate and give
that's a good idea. Because what happens is that often your GP may say, we can only deal with one thing during this appointment. But what people always do is they leave it till they're about to leave the room, and then they say the thing that makes you think, okay, well, that probably should have come first. But how would you know that? So yesterday, for example, I had a lady who said she had lost 18 kilos in the last three to 4 months, just lost her appetite completely. But that was just one more thing. I'm just, as she's leaving. So that was a definite sit down, full examination, and a referral for a possible cancer diagnosis because there were no other symptoms. So it's really important to read out the list. And what your GP will do is, some things may spark worries, so we call them red flag symptoms. So they'll be looking for those, and they may want to deal and need to deal with those first, but they will have a whole picture. So it may just be that the whole first conversation is telling them what's wrong with you, and then they start to think, right, okay, well, let's see if this could fit into a pattern. what do we need to deal with first, what's really urgent, what can wait, what can you be brought back for another conversation about. So it doesn't matter if you've got lots of things and they may not be related, but you could say, look, I have got lots of issues, I've written them down, I wonder, could you please listen to everything, and then we can work out a plan of action. And that's absolutely a brilliant thing to do, rather than, because you won't know, and sometimes we won't know. We need to know everything, and all the information is so much more helpful to us. So,
and at the beginning of that 10-minute slot. So as you say,
even saying, look, I've got a lot of things. I don't know whether they're linked, but these are the things. And here's the list. and actually, that's absolutely fine, because I find it so much more helpful, because then I can clock in my mind whether I need to take urgent action upon something. And that probably might mean that your issue may have to wait for another appointment. But if I think you've got a cancer or you're having a heart attack, I mean, people, honestly, they leave their crushing chest pain till the last second. And just got one more quick thing. And because it just is, it's very interesting how we behave. So, and that needs to be sorted out. So we have to sort that out. Equally, we're not going to leave a possible cancer diagnosis. So, but we may be able to put things, because that's what we're trained to do, put things in a bit more of a sort of symptom chart,
order of priority,
understand what to do. So it's not your job to do that, but it is helpful to us if you present everything.
Yes, absolutely. No, I remember I went to the doctor. I didn't write it down. I had it on my phone just in case, because I was thinking, I'm going to forget. I know I'm going to forget. Now, actually, I did forget to ask you. I'm going to just ask, with that testosterone that we just talked about, which is the one that you prescribe? Not saying that everybody needs to go, but if they could go with a name of something to
it doesn't matter. I think I give, is it Tostran is the 2% one that we were asked to give, and that's one every other day. You can give Testim or Testo Gel. The name of it doesn't really matter. There's guidance for us to follow. So it's just a 1% or 2% testosterone. But it's a male testosterone. It's not licensed in women, but it is safely given with appropriate guidance. There is guidance from the BMS and NICE on how to give it safely. But it can only be given for low libido.
The funny thing is, I actually did ask my GP whilst I was in there, said, okay, talk to me about HRT, and I want to talk to you about testosterone. And she just said to me that she actually cannot prescribe testosterone. What I would have to do is go to a gynecologist, or a specialist. I was thinking of you at the time, and ask them just to say, yes, it's okay. Then she would prescribe it. Now,
exactly. So that's absolutely, she's done exactly the right thing. That's what her guidance says. She's not allowed to do it. But she's happy to do it with guidance from a specialist. So that's totally fine. Great.
I just mentioned that. That's brilliant. I mean, actually, those are most of the questions. Has anybody got any other questions whilst we're here? We've got about another, oh my goodness, we've already got to the hour already. Oh my goodness. And we haven't even got to vaginal atrophy and blood tests and monitors. Is there anything quickly that you wanted to just mention about those two things that we were going to talk about?
Okay, yes, I'll do. So I think we've covered estrogen. We could probably leave the blood test, but the vaginal atrophy,
yes,
just to say, I get a lot of ladies in who describe razor blades or little cuts around the vagina, and that's the feeling they get. And so women don't understand the difference between HRT and local estrogen, because why would you? It's difficult to understand. So HRT is going to be your transdermal estrogen and your progesterone or progestogen and possibly your testosterone. But if you have bladder symptoms like urge to pee, frequency of passing urine, stress incontinence, urge incontinence, up at night going to the toilet, cystitis, so your bladder's becoming a problem, and also you've got dry vagina, feeling of razor blades and cuts down there, thin tissue, bleeding after sex. There are local estrogen creams or gels or pessaries, or a little ring that pops up inside the vagina, and the dose of that is tiny. It's about the same. One dose of HRT one day is about the same as what we would as the dose would be to insert into the vagina over a year. But what it does is keep those tissues nice and lubricated and less likely to bleed, and it will help with bladder symptoms. So, and you can start that at any age. In most women, you can start it at any age. And I see a lot of my older ladies who are the smear is really uncomfortable for them. So we stop immediately. We give them 3 months worth of local estrogen, and then things are often much more comfortable. So it's really important to know that there is also this local estrogen as well as your hormone replacement therapy. And there are lots of different types. There are low dose, there's high dose, there's pessaries, there's little applicators. You put it in every day for 2 or 3 weeks, and then you use it twice a week forever.
So it actually, the relief you can get, is that quite rapid then? So even if you
not rapid, maybe a few months, but definitely works.
But it can work. But well, I'm sure
everyone,
if it's that painful, then anything will be just a blessing, won't it? And is that from the doctor, or can you go that just to your pharmacist?
Oh, I don't think you can get it from the pharmacist.
No, so you do
it's
need
a possibility, but I can't remember. You might be able to get it short term.
Yes.
And then you have to go and see your doctor, because a lot of women will start to use it, for example, and the itch down there and the soreness down there needs to be looked at, because some women have got lichen sclerosis, they have vulvar carcinoma, they have things down there that you just wouldn't know unless you're looking at it and with an experienced eye. Certainly looking at your body is very important.
We were talking about this last time with the mirror. I could see on my face afterwards, I was a bit like...
I know, everyone gets so worried about it. It's like, oh no, I can't possibly.
You know what I'd be looking at. It's like, oh no.
But the thing is, what you'd be looking at is what you are like, and it doesn't matter what it looks like. That's what it is. So therefore, you know that if you look down there and that isn't what you normally look like, then you know that you need to do something about it.
Lip gloss is just not going to make it look better, is it? Let's just be honest. So yeah. But no, I think you're absolutely right. I mean, I think us knowing about our anatomy and how we feel is really really important. And unfortunately, we're all so different. It's not like, as you say, you can't ask your friend and say, or your mother or your sister or something, and say, this is how I'm feeling. Did you feel like? And they go, just no. It just makes you feel worse, doesn't it? But yes, it's nice to know that from a GP as well, which is so lovely that you're so into women's health and wellness, as well as what you do as a GP. I think you're just amazing. Now, what I do want to do is just to make sure that people can find you on Instagram and Facebook, because I didn't say this last time. So it's advice with the number 4, menopause. Yeah. And there's an underscore.
There's an underscore doctor. I think if you look up advice for menopause, then it'll come up. Yeah.
Lovely. So what I'm just going to recommend to all the ladies who are on here, just to actually, follow Dr. Carys. She does some amazing Instagram. I follow you on Instagram, but I know you're on Facebook as well. So, your Instagram and Facebook.
I do a little bit on Facebook, mostly on Instagram.
Yes.
Yeah.
No, that's great. And I have to say, you've got just loads of information, so you can actually just go through your grid and find the topic that's of interest to them. So really, really important that if you want to actually follow Dr. Carys, I do avidly every morning. I'm like, what have you said today? What tip can I learn?
I'm really glad. Thank you so much. I'm enjoying it. It's good fun.
Oh, well, hopefully we can do this again in July.
Absolutely.
But keep going through. And one of the things I will say is we're actually going to be popping this onto our app. We've got a web app at the moment, which is going, we're just waiting for Google to change it onto a proper app. But on our app, we give a lot more support on there. And so we do the whole of this video goes onto there as well. And I will try and break down some of this video as well, so that, for those critical topics, like we did last time, people can actually just hear what they want to listen to, which thank you so much for your time today.
Oh, it's my pleasure. Really enjoyed it. Love speaking to you.
Great. Yeah, thank you. And I've seen a few thank yous through the you can't see the comments, I don't think, on your side.
No, I can't see them. No.
But there are some thank yous. And thank you everyone who's been on today. We didn't have as many questions on here as we had last time, but we got them all in advance. So I think that was really, really useful. And and I look forward to speaking to you again really soon.
Yes, absolutely. Same to you.
Take care.
Take care.
Guys.
Bye.
I will be back on tomorrow on the Facebook group. So I'll see you soon. Take care.
Bye.